So, the term contraception includes all measures, temporary or permanent, designed to prevent pregnancy due to fertility. Ideal contraceptive methods should fulfill the following criteria: widely acceptable, inexpensive, simple to use, safe, highly effective, and requiring minimal motivation, maintenance, and supervision. No one single universally acceptable method has yet been discovered. History. History of contraception. Idea is ancient. Egypt, dusted with wine and garlic after sex. Soak crocodile dung in sour milk and inserted in vagina. Contraceptive effectiveness chart. Most effective methods: implant, cervix sterilization, less than 2 pregnancy per 100 women years. Very effective method: injectable lamp, COCs, POTs, patch, vaginal rings, 3 to 9 pregnancy per 100 women years. Effective methods: male condom, diaphragm, female condom, fertility awareness method, 10-20 pregnancies per 100 women year, and least effective methods: spermicides, 21 to 30 pregnancies per 100 women year. Now, what is Pearl index? Pearl index is total number of pregnancy, total upon total number of exposure into 100. The eligible couples are married couples lying in the age group between 15 to 45 years. Then what couple protection rate is percentage of couple using one or different types of contraceptive method. Now, what are the methods of contraception? There are temporary and permanent methods. The temporary methods are barrier methods, natural contraception, intrauterine contraceptive device, steroidal contraception. Permanent are female tubal occlusion, male vasectomy. Now, what are the natural methods? Rhythm method, calendar method, safe period, basal body temperature method, cervical mucus method, symptothermic method, coitus interruptus, withdrawal method, sexual abstinence, and lactational amenorrhea method. Now, what is rhythm method? The first unsafe day is obtained by subtracting 20 days from the length of the shortest cycle. Last unsafe day by deducting 10 days from the longest cycle. Users of temperature rhythm require abstinence until the third day of the rise of temperature. Now, basal body temperature observation. There is biphasic pattern of temperature variation in ovulatory cycle. If pregnancy occurs, the rise of temperature sustains along with the absence of the period. In an ovulatory cycle, there is no rise of temperature throughout the cycle. Interpretation. The body temperature maintaining throughout the first half of cycle is raised to 0.5 to 1 degree Fahrenheit following ovulation. The rise sustains throughout the second half of cycle and falls about 2 days prior to the next period, called biphasic pattern. There may be a drop in the temperature to about 0.5 degree Fahrenheit before the rise and almost coincides with either LH surge or ovulation. The demonstrable rise actually occurs about 2 days after the LH peak and with a peripheral level of progesterone greater than 5 nanogram per ml. As you can see in the graph, how the temperature variation occurs. Then the cervical mucus study, that is Billings method. Alteration of physiochemical properties of cervical mucus occurs due to the effect of estrogen and progesterone. Disappearance of Fern pattern beyond 22nd day of cycle, which was present in the mid-cycle, is suggestive of ovulation. Persistence of Fern pattern even beyond 22nd day suggests anovulation. Progesterone causes dissolution of sodium chloride crystals. Following ovulation, there is loss of stretchability, spin barket, which was present in the mid-cycle. Sexual abstinence. It is the only method which is 100% effective. Coitus interruptus. Main Man withdraws organs from the vagina just before ejaculation. High rate of failure. Call index is 18 per 100 women year. Now, breastfeeding, that is lactational amenorrhea method. Prolonged and sustained breastfeeding offers a natural production of pregnancy. The risk of pregnancy to a woman who is fully breastfeeding and amenorrheic is less than 2% in first 6 months. Otherwise, the failure rate is high. Thus, during breastfeeding, additional contraceptive support should be given by condom, ICD, or injectable steroid. Now, symptothermic method, it involves combination of calendar method, basal body temperature method, cervical mucus method. Then comes the barrier contraceptive. What are the barrier contraceptive? Male condom, latex, non-latex, female condom, vaginal sheath, liner pouch, vaginal diaphragm, Dutch cap, cervical cap, contraceptive sponges, intracervical devices, vaginal spermicides. Types of male condoms. Today, a wider choice of condoms is available. Types of ring and P. Contraceptive advantages of male condom. It is reliable, relatively inexpensive. It is light, compact, and disposable. Effective immediately. No method-related health risk. No systemic side effects. No medical supervision required. No follow-up required. Does not affect breastfeeding. Can be used as backup to other methods. Widely available. No prescription or medical assessment necessary. Non-contraceptive advantages of male condom promotes male involvement in family planning. Only family planning method that provides protection against the sexually transmitted diseases, especially HIV, may prolong erection and time to ejaculation, help prevent cervical cancer. Now, what are the disadvantages of male condom? Its effectiveness as contraceptive depends on willingness to follow instruction. User dependent, require continued motivation and use with each act of intercourse. Man under influence of alcohol may omit to use it. May reduce sensitivity of penis, making maintenance of erection more difficult, especially in aging men. Interferes with full genital contact and makes the act less pleasurable for both partners. Disposal of used condoms may be now the failure rate is typical use 12 to 18 per 100 women years, perfect use 3 to 4 per 100 women years, with side it is 1 per 100 women years. Now causes of failure, burst or break, slips out, past expiry date, use of condom, inconsistent use, defect in manufacturing, damage after manufacturing. Female condom made of plastic polyurethane, FC2 made of nitrile polymer, better against HIV. Latex, panty, silicone material. Contraindication 2 class 4. Women or health with physical disabilities and those who find it unpleasant to touch their with uterine prolapse, with severe cystocele, rectocele, with vaginal stenosis. Advantages of female condom: it is under female's control. It is effective immediately. Covers the external female genitalia, thus offering better STD HIV protection. It does not constrict the penis as do latex male condoms. As a result, sensitivity of for males may be better. It can be used without spermicide, like the diaphragm, cervical cap, and sponge. It can be inserted well before intercourse. It is stronger than condom and less likely to rupture. It can be used during leukorrhea, superficial dyspareunia, and in purpurium. It can be used with any type of lubricant without compromising its strength. It can be washed and reused up to 7 times. Disadvantages of female condom: couples may find it unappealing. Difficulties in insertion removal. During vigorous use, it may be put into vagina. It's relatively expensive, user dependent, required continued motivation, moderately effective. Effectiveness depends on willingness to follow instruction. Effectiveness and failure: perfect use 1 to 9%, typical use 3 to 22%. Failure 5 to 21 pregnancies per 100 women here during first year of use, causes breaks and slippage. Vaginal diaphragm Dutch cap types: flat spring, flat band of metal, coil spring, spring wire, arching diaphragm, coil and flat hinge flex, Advantages: moderate protection against STD, lack of systemic side effects, reversibility, low maintenance. Disadvantages: require manipulation of genitalia, requires efforts to keep it clean and hygienic. Motivation is must. Vaginal diaphragm effectiveness: typical use 10 to 2800 women years. Perfect use is spermicidal. The side effects are sensitivity to material, inflammation and erosion of vagina, increased frequency of urinary tract infection. Cervical cap: one-third of rim is filled with spermicidal gel, cream foam, then rim of cap around the cervix until the cervix is completely covered. In nulliparous, 16% with typical use, 9% with perfect use. In parous, 32% and 9% with typical and perfect use respectively. Then the contraceptive sponge consists of medicated polyurethane sponge, which is soft and flattened, sheath with simple on one side to fit over the cervix and nylon loop on the opposite that helps in removal. Acts as a reservoir that takes up the ejaculate into the interior of the device. Contains 1 gram of nonoxynol 9 as a spermicide. Another type has polyvinyl alcohol and 5 gram benzalkonium chloride, available in only one size. Now, intracervical devices have flanges or protruding wings to anchor them in cervical canal, may be medicated or non-medicated. Act by blocking cervical canal, vaginal spermicides. These are safe and simple to use, acceptable to patients with probable protection against STDs and also provide lubrication. Spermicides are used mostly in combination with mechanical methods, condom, diaphragm, cervical caps with lubricants and adjuvants. Agents: type jelly creams, paste. Example: Delphin cream, pressurized foam, Delphin foam, suppository, foaming tablets, today dissolvable films. Active spermicidal agent, use surfactant agents. Agents types: jellies, creams and pastes. Example: Delphin cream, pressurized foam, Delphin foam, suppositories, foaming tablets. Example: today dissolvable films. Active spermicidal agents, use surfactant agents: phenyl mercuric acetate, monoxynol 9, octozynol and menthegol. Then the intrauterine devices. What are the definition? The contraceptive device fitted inside the uterus and physically preventing the implantation of fertilized ovum. The device is classified as open when it has got no circumscribed aperture of more than 5 mm. Lippies loop, CUT, CU7, multi-load, progestra, SERV. Types of IUD: non-medicated as Lippies loop, medicated by incorporating a metal copper in device like copper T380A, multi-load 250, multi-load 375. Hormone containing IUD, either releasing progesterone or levonorgestrel. Nowadays, the following medicated intrauterine contraceptive devices are in use: CUT 200, multi-load 250, multi-load 375. Copper T380A, levonorgestrel, IUS, and Gynefix. Intrauterine devices: type non-medicated or inert IUD, medicated or bioactive IUD, first generation IUD, the non-medicated or inert, second generation is copper, and third generation IUD is hormone releasing. Mode of action, mechanism of anti-fertility effect of all the IUDs is not yet clear. They act predominantly in the uterine cavity and do not inhibit ovulation. Probable factors are biochemical and histological changes in the endometrium. There may be increased tubal motility, endometrial inflammatory response, decreased sperm transport. Copper devices: ionized copper has got an additional local anti-fertility effect by preventing blastocyst implantation through enzymatic interference. Indications for IUD contraception: emergency contraception, dysmenorrhea, menorrhagia. Contraindication for insertion of IUCD: presence of pelvic infection, current or within 3 months, undiagnosed genital tract bleeding, suspected pregnancy, distortion of uterine cavity as in fibroid or congenital uterine malformation, severe dysmenorrhea, past history of ectopic pregnancy within 6 weeks following cesarean sections and sexually transmitted infections, Significant immunosuppression additionally for copper T, Russell's disease, copper allergy for levonorgestrel IUS or hepatic tumors of hepatocellular disease, active current breast cancer, and severe arterial disease. Now the time of insertion interval when the insertion is made in the interconceptional period beyond 6 weeks following childbirth. When the insertion is made in the interconceptional period beyond 6 weeks following childbirth or abortion, it is preferable to insert 2-3 days after the period, but it can be inserted anytime during the cycle. Even during menstrual phase, which has certain advantages. However, during lactational amenorrhea, it can be inserted at any time. Post-abortal, immediately following termination of pregnancy by suction evacuation or DNU, or following spontaneous abortion, also prevent uterine synechiae. Postpartum can be done before the patients are discharged from the hospital because of high rate of expulsion. It is preferable to withhold insertion for 6 weeks when the uterus will be involuted to near normal size. Post-placental delivery, insertion immediately following delivery of the placenta could be done. Methods of insertion of copper T200, history taking and examination to exclude any contraindication of insertion. Patient is informed about the various problems. The device is shown to her and consent is obtained. The insertion is done in outpatient department taking aseptic precautions without sedation or anesthesia to reduce cramping pain. Ibuprofen may be given 200-400 milligram 30 minutes before insertion. Placement of the device inside the inserter. The device is taken out from the sealed packet. The thread, the vertical stem, and the horizontal stem folded to the vertical stem are introduced through the distal end of the inserter. The device is now ready for the introduction. No touch insertion method is preferred. Actual steps: the patient empties her bladder and is placed in lithotomy position. Uterine size and position are ascertained by pelvic examination. Posterior vaginal speculum is introduced and vagina and cervix are cleansed by antiseptic solution. The anterior lip of the cervix is wrapped by Alice forceps. A sound is passed through the cervical canal to note the position of the uterus and the length of the uterine cavity. The appropriate length of the inserter is adjusted depending upon the length of the uterine cavity. The inserter with the device placed inside is then introduced through the cervical canal right up to the fetus. After positioning it by the guard, the inserter is withdrawn, keeping the plunger in position. Thus, the device is not pushed out of the tube but held in place by the plunger while the inserter is withdrawn. The excess of the nylon thread beyond 2-3 cm from external os is cut. Then the Alice forceps and posterior vaginal speculum are taken. No touch insertion technique includes loading the IUD in the inserter without opening the sterile package. The loaded inserter is now taken out of the package without touching the distal end. Not to touch the vaginal wall and speculum while introducing the loaded IUD inserter through the cervical canal. Instructions to the patient. The possible symptoms of pain and slight vaginal bleeding should be explained. The patient should be advised to feel the thread periodically by the finger. The patient is checked after 1 month and then annually. IUD shelf life. Progesterone at 1 year, copper T 4 years, copper T 3 to 5, Mirena 5 years, Levonorgestrel 7 to 10, and copper T 388 10 years. Complications: immediate cramp-like pain, syncopal attack, partial or complete perforation, remote pain, abnormal menstrual bleeding. Menstrual loss is much less with the use of third generation IUDs. PID is 2 to 10 times greater amongst IUD users. IUD, copper devices and hormone releasing IUDs. Advantages: it is inexpensive. Copper T distributed free of cost through the government channel. Simplicity in technique of insertion and most cost effective of all methods. Prolonged contraceptive protection after insertion and suitable for the rural population of developing countries. Systemic side effects are nil. Suitable for hypertensive, breastfeeding women, epileptic. Reversibility to the fertility is prompt after removal. Disadvantages: require motivation, limitation in its use. Adverse local reactions manifest by menstrual abnormalities, PID, pelvic pain, and heavy periods. Besides, side effects are less with third generation of IUDs. Risk of ectopic pregnancy, failure rate is 0.1 to 200. Thank you.